Thanks, Pat, for the chance to come talk to the council, and thanks to Dr. Wingate and Dr. Cashin too. They have been great encouragers since I arrived here in January. I think, it's been a year of a lot of transitions at the clinical center, and there were some events that precipitated that you might have read about in the newspaper. Not exactly the kinds of things we like to have out there about the clinical center. And one of them was the closure of the clinical center pharmaceutical development section. And the issues in the clinical center centered on the pharmacy, but they weren't just in the pharmacy. And because they were deemed to be more systemic and not just pharmacy related, there was the advisory council of the director of the clinical center working group established a red team that was led by Norm Augustine. And in that report that came back from the red team, there were some discussions and recommendations and priority areas, and that the NIH Clinical Center particularly needed to fortify a culture and practice of safety and quality. And we had to address sterile processing, particularly in the pharmacy areas, but in others as well. Transfusion medicine would be another big area that's involved. And there needed to be some changes made to address leadership for clinical care quality oversight and compliance. And that's then what led to an executive search that I ultimately was selected. So these are some of the new leadership changes. First of all, we have an external hospital board. The first meeting was in July of 2016, been 5 meetings to date. And again, the purpose of the board is to provide really advice and recommendations to the NIH director on clinical center policies and procedures for hospital operations. This is not a group of researchers. This is a group of hospital and healthcare leaders. Laura Farisi is sitting next to Dr. Collins there on the bottom row, and Laura is the COO for Columbia Presbyterian Hospital System in New York City. Peter Pronovost is standing right behind Dr. Collins. Of course, Peter is I call him the Pied Piper of patient safety. And Peter and I got to know each other pretty well when I was at Johns Hopkins, and he's been a big supporter. Rick Shannon is upper right. He, I think, runs the health system for the University of Virginia. And I won't introduce all of the rest of them to you. Jeanette Eves Erickson is on Peter's right, is from I think Brigham and Whitman's in Boston. So she is a very important contributor to the group. And then the second thing that needed to happen was to sort of separate responsibility for the scientific program in the clinical center, which is really very, very important and very, very near and dear to our hearts, from really healthcare operations. And so I run the healthcare operations side. I'm responsible for patient safety, staff engagement. I have had to do a lot of revisions of the organizational chart, and I'm responsible. And most of the money gets spent on my side. Then John Gallen, who was the director of the clinical center, is also a very accomplished researcher, and he has the new titles of Chief Scientific Officer and the Associate Director for Clinical Research. And so he has responsibility for the scientific program that's conducted in the clinical center, and that includes the responsibility to prioritize some scarce resources. For instance, one of the really active topics at the NIH now is cellular engineering. And if in order to do as much cellular engineering as the investigators wanted to do, we would have to have about 5 times the capacity that we currently have. And so how you decide whose science gets to go first at the NIH is really kind of a challenging role, and so that's one of those that I'm very happy that John has. And John also, as somebody who's been at the NIH a long time, is also responsible for the strategic partnerships. So this is just a little bit about me, and I won't dwell on this since Dr. Grady sort of went over this. I am not a scientist and researcher by background. My undergraduate background is in engineering, which is 4 years of learning how to solve problems. Turns out that background comes in handy quite a bit. And I was a cardiac electrician at one time, and I did have a lot of time in executive hospital leadership in DOD before, and only in the United States Army would they give you oversight of medical research and development and not have been a researcher beforehand, but I did that for 4 years at Fort Detrick. So this is the new mission statement. I was assured that Dr. Collins would have a lot to say about our mission statement. We actually got the mission statement through on the very first pass. We provide hope through pioneering clinical research to improve human health, but we never show the mission statement without showing the guiding principle number 1, and that is, that illustrates our individual and collective or team passion for high reliability and the safe delivery of patient-centric care in a clinical research environment. The challenge is to balance patient safety with and to take care of all those things that you can take care of, either with additional resources or additional planning or additional safety measures, while understanding that there are some things about clinical research, especially the kind of first-in-human trials that go on in the clinical center, that you just are not going to always be able to plan out. And there are going to be some black swans, and they are going to happen, and you do need to be willing to accept that that's going to happen, but only after you've done everything you can to try to anticipate everything untoward that can go on. So it's elimination of preventable harm, accepting the fact that it's not all going to be preventable. We opened a new interim intravenous admixture unit, so we got out of the old pharmacy. We have a much better facility, much more GMP compliant, FDA happy place to do our IV work. Dr. Majid Tanas is standing there with the bow tie. Majid is our new chief of pharmacy. He came to us from the Oregon Health Sciences University, and we are very, very happy that he is here, and Dr. Collins came over when we cut the ribbon on the new IVAU. Creating GMP compliant facilities in an old building, and particularly in the worst part of an old building, has turned out to be really quite a challenge for us. We do have some scars from that process. We have a number of delays that have come from that process. But we are getting better at it, and we are getting better at understanding that business. And I think the next one is going to come online in January, which will be a new cellular processing facility. These are some of the things that we have done, focused particularly on patient safety and clinical quality, and I'm not going to read all of them to you. This is only 8 months worth of work for us. And I think it all tracks to the reason that I was hired. My application for this job, my letter of application, was all about patient safety, high reliability in healthcare, and clinical quality. And this is the way I spend the first part of almost every day. I first start out when I first get here. I click on our new patient event reporting system. It's called STARS. Now, I'm a retired Major General. I really wanted to call it 2 stars, but they said it could only be called STARS. And the first thing I do is I look down the one column that's probably difficult to read that says, did this event result in harm? And I obviously pay a lot of really, really close attention to that. And I get these 7 days a week. I can look at them at home. We went from an old event recording system to this system in April. The first month we had this system, we had more reports than we ever had in a single month in the old system. One of the basic tenet of high reliability is absolute fascination with the possibility of failure, and so we want to have a very low threshold for reporting. We think we've achieved that over 500 to 600 a month, and it's a closed system. That is, every one of these will be closed out. The response for every one of these will be entered into the system before it's all over. We have a patient safety huddle Monday through Friday at 8:40. It lasts 20 minutes. It is rapid fire. It's so rapid, we don't sit down, we stand up. It's a pretty popular 20-minute meeting. We have people there from all across the hospital, every major nursing unit, all the supervisors, where we talk about the things that happen overnight. We talk about the things that we anticipate happening during the day. It is really the backbone of our focus on patient safety and clinical quality. It was in place before I got here. I was just smart enough not to do anything with it and to continue it. And it continues to this day to be the backbone of what we do. The third thing, and I don't do this every day, but tomorrow's Wednesday, so tomorrow's my day, is we do patient safety rounds in the clinics and in the inpatient nursing units. And we ask the people there, what are their concerns about patient safety, and what are the things that they would like us to think about trying to do something about. And they've been very, very receptive. And they come up with some amazing insights that we would never get in the C-suite on the 6th floor. Absolutely amazing insights. And it's not like these things are resource intensive. They come up with some very practical ideas that are making a real difference. And they know that we're serious when we go out and talk to them about patient safety and clinical quality. And I usually start the conversation with, have you ever said, if that CEO ever came down and talked to me, this is what I'd like to tell him. That's what I want to hear about. And I would say so far it's been very, very gratifying to see how interested they are in doing this. We are improving our care. We're not a general hospital. There are things we don't do. As a guy who spent 35 years in the military and military hospitals, we don't deliver babies. That's something that every military hospital does. So we don't deliver babies. We don't have orthopedics. We don't have an emergency room. Actually, an unplanned clinic visit is actually a reportable event in our system because there's a lot that has to be done to be ready for that patient who's visiting on the complicated clinical protocol. So there are a lot of things that make this unique. We don't have primary care. So there are some things that you have to think differently when you're working in a health system like that. But because we are interested in things like gene editing, and because we're interested in intervening in congenital diseases at an early stage, things that children have, we are trying to buff up our ability to take care of children. Well, I don't think we'll ever be in the neonate business or in the pediatric intensive care business, at least not for a long time. But we are improving our quality to take care of small children and think about taking care of children that even a little bit smaller as time goes along. This is very, very important to us. The NIH Clinical Center, the culture is maybe a little bit anachronistic about some things. So one of the things, I don't know how many of you were exposed to morbidity and mortality conferences that physicians used to conduct in the old days. But this is the way they worked, okay? It was a small group. They were feared. To have to present a case at M&M was a bad deal. That meant you were in trouble, probably. Because no matter how, as a young physician, it was, things happened, it was gonna be your fault. No matter what, it was guaranteed it was gonna be your fault. It was the ultimate naming, shaming, and blaming exercise. Absolutely was. And so what we've tried to do in the clinical center is to open those conferences up, to bring them out into the open. Our lawyers are a little nervous about this, but so far it's worked out pretty well. The first one, we probably spent 200 to 250 hours preparing that case. It was a very complicated case. We had that much to talk about. And we spent a lot of that time just convincing the physicians who were involved that we could do this. Now, the second time it was a much simpler case and probably didn't take nearly so long, but it still took some convincing. Each one of those, we exceeded the capacity of our small auditorium, Lipset Auditorium, for each one of those. So, and everybody thought they were wonderful except the fire marshal. Fire marshal came in and threw people out of the room, which didn't make us very happy, but everybody else thought that was great. And now we're gradually changing the culture that we can talk about things that don't go right, that we can talk about them publicly, and that everybody should have the chance to learn from these kinds of cases and not just those that were most involved. But you have to prepare carefully, or else it'll turn into a naming, shaming, and blaming conference again. And I think we're doing a pretty good job of doing that. We're very proud of these now. We have to get into the business of research and regulatory compliance. And so what are we trying to do? We're trying to build a culture of quality when it comes to clinical research while making compliance and compliance with all regulatory oversight easier. And so one of the things that we're doing with Dr. Gottesman's Office of Intramural Research, Dr. Wyatt's here representing that office, is to create an Office of Research Support and Compliance within the Clinical Center that did not exist beforehand, and we're not fully up and running yet. It will be, especially for those institutes within the NIH that are smaller, maybe don't have the necessary resources to provide all of this research support and compliance oversight on their own. The Nursing Institute has been one of the biggest fans for this. They really want us to get this going. They have great plans for that office, and we want to be there for them. And we want to link this to our efforts in patient safety and clinical quality. We want regulatory compliance and serious adverse event, unanticipated problem reporting, and our clinical safety and quality groups to be absolutely joined at the hip and connected and not separated. This is what the office will look like if we are fully resourced. In the upper left is actually our regulatory, our current Office of Research Support and Compliance. These are the people that have a lot of FDA and Red Cross expertise, Red Cross Blood Bank expertise, and they are proving to be a great group of folks to solve problems, and they're even better at preventing them, which is a really good thing. We are very proud of a recent award. Some of you may be familiar with the National Research Corporation. We use them a lot for some of our surveys of our patients. And last month, Natasha Pointer, who is the exec for our Medical Executive Committee, went to Boston and received an award for in their surveys, we were #1 in terms of the emotional support we provide our patients. So these are patient surveys. That plaque, it's a very nice plaque. It's making the rounds around the hospital now, since it wasn't won by those of us on the 6th floor. It was won down where care is provided. It's making the rounds of the hospital. I sent our communications staff with it. I said, take your camera. This is like the Stanley Cup, okay? This is like the Stanley Cup. And particularly for those people who were around a year ago when the Red Team report came out and everything else, this is a really good thing. The picture we had in Boston for the backdrop of the presentation of the award, you can't see it, but it's a young girl who was here, and it was snowing outside, but her immune status was not sufficient to allow her to leave her room and go out and play in the snow. So, of course, our nurses went out and got the snow and brought it in for her, which is just a wonderful thing. And that goes on regularly in the clinical center. We have a very, very unique special population. We have for years talked about them as our partners in the research enterprise. But the way I described it when I applied for this job was I spent 35 years in the United States Army, and I loved taking care of people who derived their health care benefit by virtue of the fact they were doing something for all of us, okay? And from my standpoint, the patients who are our partners in research are doing the same thing. They sign up for these protocols with the hope that they personally will gain, but they do it with the assurance that we're going to do the research in a way that allows us to derive lessons that will apply to everybody else who has their problem, and sometimes to those who have unrelated problems. Another one of our guiding principles, there are actually 7, which sounds like a lot of guiding principles, but guidance is good, right? So 7 guiding principles: diversity and inclusion of people and ideas. And that certainly relates to the kind of interdisciplinary teamwork that we expect from clinicians and scientists and the nursing staff and everybody else. The top 2 pictures, Project Search is a program for intellectually and developmentally disabled folks. We've been doing it 7 or 8 years here at the Clinical Center. There have been a total of about 72 graduates. Roughly 2/3 of those people go on to full-time employment, either here or someplace else in the federal government. It's a very active job coaching kind of program, and these we find a number of these people make wonderful employees. We do we do have quarterly town hall meetings until people stop showing up for them. So far, they still show up, and I promised them that if they showed up, I would keep having them every quarter. They have been a very interesting. The most recent one, we started just presenting the length of service awards from 40 years, 35 years, 30 years, all the way down to 5 years. That's the first time when you work for the federal government, you actually get one of these length of service awards with the thought that you shouldn't just get that at your desk. It shouldn't arrive in the mail. It shouldn't just be something that's handed to you by your supervisor. But if you want, it should be done in a very public forum, and it should be done by the CEO, and you can have your picture taken if you want, okay? And, oh, by the way, you shouldn't have to be here 25 or 30 years before that happens for the first time. It should happen, and quite naturally, I'm used to, kind of regular award ceremonies and things like that. And we did this for the first time in July, and it's been well received, and now we're trying to figure out, because there are a lot of people that have to get these awards. This is our National Institute of Nursing Research clinical activity. I will tell you that it's not enough, okay? And I think we have the real possibilities for growing this over time. And I think we have the staff in the clinical center. I'm still sort of in the middle of this search for a chief nurse executive, chief nurse officer. It's been a very long process for me, my first at the NIH. But I have a wonderful acting chief nurse executive. If you didn't know better, nobody could tell she was acting, and she's done a great job. And she is a great collaborator and has been a great partner in helping me get started here at the clinical center. We do have the opportunities for collaboration, and I think my slide is a little dated. As I understand, the bench to bedside, there actually is one for 2017. And so my slide, I was paying attention that there is one that's not on here, but we do have opportunities for collaborative research that it can involve institutions outside of the NIH campus working with NIH investigators. We would encourage you to think about those and to explore those with us. And that is it.